I'm Mindy Tueller. I manage the medical home portal and I facilitate this meeting, and it's great to see you all this morning. I hope traffic wasn't too bad, and we had kind of a small group in October. I don't know if that had something to do with being right before the UEA break, or there was something else going on for some people I know, but we're happy to see you here today, and I think we have a few people on the line as well, so that's terrific. Okay. So let's go ahead and get started with some introductions, as we always do. So we'll go around the room, and maybe we'll ask the people on the phone to go first, and that way we won't forget about them.
All right. Ashley or Melinda, can you unmute your phone and can you introduce yourself, please?
Sometimes the unmuting can be hard.
Or you can type it in the chat box, and I will read it out loud. Well, while they do it, why don't I start?
Okay.
Well, Ashley writes, I'm in a tablet, sorry, but Ashley Barney, LPN Care, Care Coordinator, UBP Patients.
Great. Good morning, Ashley. Welcome.
Good morning, Ashley. Yes. My name is Gabi Baragoshi, and I'm one of the quality improvement coaches at UPIC.
My name's Aaron Smoothie. I work with the Competition for a Healthy Environment.
Great, welcome.
Thanks.
Claudia Bruin, working on this issue.
Claudia will be presenting to us in a few minutes.
I'm Eric Christensen. I manage the Integrated Services Program with the Maternal Child Health Bureau at the Utah Department of Health. Walt Torres, Eric Struth.
Marilyn Howe, Care Coordinator with Eric Struth. Carrie Martinez, Care Coordinator.
Ben.
Tony Estrada, Care Coordinator with Integrated Services.
You only understand.
Heather Carlson, part of the clan. Margie Kiesel, Pat Rowe, Care Manager with Select Health. Veteran Care for Integrated Without Pediatrics. Cindy, Care Coordinator without Pediatrics. Amy Spears, Care Coordinator, Auto Pediatrics. Coordinator for Delivery Case. Bill Connor, Referral Development. Young with Little Creek Pediatrics. Kim Lane with the Medical Home Portal. Resources.
Great. Terrific. All right.
And then we still have Melinda Tibbles on the phone. She is a care coordinator at UVP, Utah Valley Pediatrics.
Great. Utah Valley is well represented today. That's great. All right. So we don't have Gina Solomoni with us today. She's at a meeting out of town. So this is more for me than it is for you, although it will ultimately be for you. So let's try not to forget to get validations. I think I have this reminder on the last slide too, so we'll make sure of that. Okay, so a few announcements. Wanted to let you guys know that we have updated some of our pages on the medical home portal around care coordination. I'll just pop out quick and show them to you. So the information hasn't been changed dramatically, just updated a little bit and reorganized for what we hope will be easier use. So rather than having long pages, one or two, we've separated out information into a number of different pages and, again, reorganized it, so hopefully that will be a little bit easier. So for those of you who may not have ever looked at these or, are new, just to let you know that we do have this section on the medical home portal that it's really about building a medical home. So it's got information in here, not only about care coordination specifically, but about children with special health care needs and kind of the definition of what that is, and from maybe a federal standpoint. And an AAP standpoint, then again, as I mentioned, information on care coordination. So some of this we would think would be very relevant for you all. And then we do have a little bit of information on how to do coding. And so some of the information that we've received over the time that UCCCN has been in existence, we've added here as we learn more about, coding for care coordination services, we make sure that it's here. So FYI. All right. And then our next announcement, we'll have Margie Capel come up for just a second and talk a little bit about an effort that's going on around CHEC. Ooh, I should have put CHEC. Yeah. So that's an acronym there. But Margie will come up and talk a little bit about an effort that's going on with Voices for Utah Children. And I have that website up. Do you want me to talk to that?
Yeah, that's great.
Okay. Thank you.
So Dr. Costco is a meeting for vaccines for children, and he asked me to just make you aware that CHIP is on the block for haircuts. And so he's needing stories from all of the care coordinators to be sent to,
There's 3 places you can share it.
if you'll write it down.
Oh, I'll send it out. Yeah.
Okay. Yeah, thank you. If you'll just share stories on how CHIP can help some of your patients. Perhaps they were unsure, they needed testing. We found problems that are going to take tests and genetics, some kinds of things to get involved with. I know that's what we have going on in our office. But she really has a passion for helping these children, and I would hate to see the program cut because they know the importance. So if you'll please, today, if at all possible, the sooner we get the information to him, the harder he can fight for these kids and advocate for them. So, and if you have any questions, he welcomes your emails. Utah Children welcomes your emails. Find out what we can do to help keep kids with us.
This was just a quick question, Margie. You may not know the answer to this, but when the care coordinators send these stories, they're not going to be able to put, names and so forth unless they have permission. So would it be appropriate to do kind of a nameless, anonymous sort of a thing first, and then potentially talk to the families to see if we can get their permission, and maybe even?
I would get the family's permission first and ask if you can use a pseudonym. If the parents want to use their name, just have them sign a release for you that it's okay. I know in the past when he's done this kind of thing, it's nice to be able to meet the family and put a picture with it, but we certainly need to have permission from the family in writing that it's okay. But a pseudonym temporarily would be the best. Great. Make it real. Make it a hard thing, so let them know why we need this.
And so I'll go ahead and send out an email right after this meeting that includes the link to this page and kind of what Margie has said. Thank you. But one thing to just add to this is that Family Voices and Family-to-Family Health Information Centers, every state has one. So UC Family Voices is the one for our state. Their money is tied to CHIP money. So if CHIP survives, then UC Family Voices will continue to hopefully get funding as well. So there's kind of an added impetus to have you find and send those stories if you possibly can. I felt a little badly that Gina wasn't going to be here because this would directly benefit, her staff and her team as well, making sure that funding source gets back in front of Congress and they understand the importance of it.
And this I'm understanding because it's just Medicaid and CHEC, is it just the CHIP portion? Or is it?
Yeah, I think, I haven't read this, I just saw this morning, but what we're talking about is specific to CHIP. So there might be things attached to CHIP because that's what they do is they'll put in riders and that sort of thing. But this particular effort is around CHIP funding only, and it's not tied to Medicaid. That's what needs to go back in front of Congress. All right. Okay, and then we mentioned this last time. I'm mentioning it again, and in fact, I think I'll go ahead and send out a. Oh yes.
Could you just ask about the time frame when they're going to make a decision? I think he told me mid-December, but I'm not sure.
So
the sooner the better.
Yeah. Oh, definitely for the stories, the sooner the better. The funding actually ends, I believe, the end of the year. So the 31st. And so what needs to happen is Congress needs to be aware enough of it that it gets on their agenda prior to them recessing for the holidays. Otherwise, it will end, and it will affect Utah kids. So it will affect kids throughout the country, but it will definitely affect Utah kids if it doesn't get put back in front of them, and then, of course, they have to vote to continue to fund it. But I think that there's a chance that it might not even get put on the agenda. So that's what this effort is about. That's what I've been hearing, anyway. Okay, yeah, so our spring 2018 UCCCN learning session is going going to be on a Friday this time, the morning of Friday, March 23rd, and we'll do it again at in Fort Douglas because the University of Utah is on spring break at that point, so lots less traffic. Hopefully make it worth your while to get up there. And what we hope is that, you know, you guys will come and you'll bring with you members of your care team and of your office. Because what we're planning on doing, and this is a little premature, but this is our plan, and I hope that we'll be able to bring it to fruition, is that we're going to ask for 2 panels to be there. And the first panel will be families and consumers, and then the second panel will be subspecialists, and maybe a primary care physician as well, but a variety of types of subspecialists for children. And what we want to talk about is care coordination, and we want to hear from families what it is that they're getting and is working, and what it is that they're perhaps not getting as much as they need, and what it is they need. And we'll also talk with them about what their role is, maybe currently, but also what their perceived role could be and what their ideal role could be. And so what we want to do is have a robust discussion around care coordination, and we might, if we have time, pick a couple of very specific topics too, not just general care coordination topics. Those might be around diagnosis, it might be around transition, it might be around mental health. We'll see who we end up getting on that provider panel. But then what we're going to do is toss those questions back to the providers and really have that discussion with everybody in the room about, you know, what are we doing now, what can be done better, you know, what's going to ultimately benefit these families and these children. So I think it'll be quite a good session, and we hope that you can make it and bring those members of your office who can benefit from that as well. Great. Okay, so we're to our brainstorming time, and we hope that some of you have some things that you'd be willing to share with us, including folks on the phone. If you want to just type in the chat box, Gabby can see that, and she'll read those out if Ashley and Melinda have anything. But
We also have now Jade Porter joining us.
Welcome, Jade. Okay, so yeah, and this is also a time not only to ask for help from those in the room if you're running into barriers with cases at all, but also if you've got any news to share, whether it's a new resource that you've been made aware of, whether it's a win that you've had. We love hearing positive stories. Whether it's motivational interviewing that you've put into practice, whether it's quality improvement effort going on in your office. And of course, we want to talk a little bit about quality improvement around screening as well today in the course of our meeting. So I will open it up. Anybody? Yeah, Tony.
I worked with a mom yesterday. She was living in Salt Lake, had some domestic violence situations happening, became homeless with her 7-year-old autistic son. They were living in a shelter for 5 months, and then she was pregnant, became pregnant, and decided to put her baby up for adoption. And so the adoption agency has got them into an apartment. But when she gives birth in January, she will have to vacate the apartment they're living on in Memphis. And so she is on the waiting list for the Section 8 housing, but that's 5 years. And just, has no food. She's Spanish speaking, doesn't know where to go, doesn't have any family. Just, everything's been thrown at her. So, if anybody knows of, inexpensive, they live in Layton. That's where they're staying right now. That's where the adoption agency found them an apartment. So they're currently in Layton. Lived in probably previous to that. So, if anybody knows of any inexpensive living arrangements or something for this family.
I have to say, and I wish Gina was here because I have a feeling she'd have some thoughts and some insight on this. We definitely have quite a number of entries in our housing service category on the Mental Health portal, particularly for Salt Lake. And we can take some time, Kay and I, to try and find some things that could be of value and send those out.
Okay.
I'll also reach out to Gina, before we send the resources of the month.
Jade wrote, I think Lifestart Village waitlist is much shorter than Section 8, but it's here in Salt Lake City.
What kind of village?
It's Lifestart Village. Lifestart. Mm-hmm.
We've got that. I think I've heard that. Is it in,
It's a 3-year program, she says.
3-year program? I feel like I've heard of Lifestart before.
What about churches? Can churches help? It starts with dorms, moves to rentals, and then helps them buy a home.
Yeah, I think I have heard of this.
Lifestart, that's how she wrote it, yeah.
Does Jade know where it's located?
Jade, do you know the address besides Salt Lake City? He's writing.
Well, it looks like we're gonna have to research that
Yeah.
one. That sounds good. Okay. Okay, yeah, we'll work on that. It sounds like a very difficult situation.
Oh, she put up a website. Can you go to the chat box? And then you can maybe click on the link. Lower? Yeah, yeah. Yeah, can you see that? Yeah.
Family Support Center, okay. That's what the problem is. We don't have the keyword Lifestart in there. We definitely have Family Support Center in there.
In Taylorsville.
Taylorsville, okay.
Mm-hmm.
Nice.
Thanks, Jade.
Thank you, Jade. This does sound like it, you know, if they have the availability for her, this could be a really good, really good place for her, so, okay, great. All right, anybody else?
This was probably one, I have a family that is an insurance issue, that they don't have any special needs, I'm just talking about because they're having a hard time with insurance, so. Parents are married, they're both under 26, so they have mom and dad insurance. And they have a baby that is, they're uninsured, and they're being told they make too much money for Medicaid, and then they send in these applications, and then they never get back to them, so they go into the Medicaid office, and they tell them that they can call, and they raise them this like 4 months back and forth, can't really talk to anybody, have to come into these papers, and they don't get these papers. Like, is there an easier process of, I mean, that just seems like 4 months is really excessive to me, and back and forth, back and forth, back and forth, back and forth. I've even gotten on her page with her to say, hey, maybe you're just missing something, and it's, you need these papers. She goes, okay, well, I sent them in, and I sent them in, and just like, there's a contact person, there's an easier way.
What is the status of the case right now? If you go in and you look and, you know, the Medicaid system, is it showing it pending still?
I'll have to check
For
that.
them. Because one of the things is, they generally have to make a decision within X number of days of when you submit the application. And so, usually, back in the day, we used to send out what's called a Form 20, but it was a list of documents that you had to provide in order to verify, you know, certain pieces to determine your eligibility. And you had a certain amount of time to get that stuff back in. So like 30 days, once you got the notice, to get the stuff back in so they can process your case. They can't usually keep a case in limbo for forever. So I'd be really surprised if after 4 months, it is still sitting in a pending status, this far out, you know, 120 days out. Because usually a determination has to be made.
I think she's had to reapply again.
Right.
And one of their problems was one of the months they submitted was like had 3 pay periods in it or something weird, like, so like their income was higher because of that month. So do they take that?
Well, one of the things though is they used to do prospective budgeting, so they would figure that if, you know, you would have 26 pay periods a year, and they would calculate, like 2.3 pay periods per month, so you could just take an average. Because back in the day, when they would do retrospective budgeting, you would be eligible, and then you would submit verification, and all of a sudden, you wouldn't be eligible because you had those higher months. They would do prospective budgeting so they could calculate those fifth pay period months, so that, you know, there's generally an average there. So, unless things have changed, and that could very well be the case, but, they should be going off of actuals. They should be looking at, we used to ask for 2 months of check stubs. Because inevitably, if you only ask for one, it was always that month you had to sit paper.
Right.
So if you have 2 months there, it's going to show 4 pay periods in 1 month, if they're paid weekly, 5 in the other. You then do that retrospective budget or the prospective budgeting, and you're able to have it.
And are 40, 15-minute wait times to talk to somebody, is that how it is?
If you're calling through the eligibility, service center, yes. Were they able to, when they initially applied, did they have a live appointment with someone who didn't invite with them to get all of this going?
I don't think so, I think it was online.
Has it all been online?
Yeah.
I have someone and I got onto my case, it's not like you got on or two, so you can get on as a third party. I just had to have her sign a release, send it to DWS, and then I can get on just by myself and look at it. And so I went on last week and it says, that the decision has to be made by, November 22nd. So it sounds like what Eric is saying, that they do give you that date once everything's in. They had to send out some paperwork because they're, instead of considering this one for PCN, they're considering her for Medicaid disability. So whenever they do Medicaid disability, they send out a disability addendum waiver. And then they have to fill that out, send that back, and then everything's considered, and now they'll give you a date of their decision. So I wonder if you get back on there and everything's in now, you'll have that.
One of the things you should be able to look at is you should be able to look at the communication history that will show you if a denial was ever sent, what was the reason. So was the reason that you made too much income? Was it that you were non-compliant in returning the forms that you needed to submit? I got to tell you, when they've done all of this on an automated scale, like for the eligibility service center, they are getting thousands of documents a day that have to be scanned to a case. Very possible that stuff gets sent in and gets scanned to the wrong case. I can't tell you how often someone would come in and might pull it up and it was the wrong person. So it doesn't happen all the time. They're pretty good to make sure a case number gets on and they can match it up. But, you know, you'll want to look at the history of the communication and determine why they were denied in the first place. So again, if it was for income, figure out why, or if it was just for non-compliance, that there were 6 things we requested, we only got 5 of the 6.
Yeah, I mean, they're not, due to the cost side, the Affordable Care Act allows for that. Many insurance companies will sell an individual, just a really inexpensive animal health. They can purchase. Some markets.
Well, a baby in good health, it probably wouldn't be too outrageously expensive.
Well,
If the baby's health, it's probably not going to be too crazy.
Yeah, then you have, you can do it online, like early residential calling, because they make, in my experience working with parents, there are a lot of, just errors in documentation, when they put 2 and 7 3, and it screws everything up. So I put it back on into the body, and so the enrollment for that particular, depending on whatever insurance company they do sell, individual.
Yeah, so I'll just speak up a little louder so that the people on the phone can hear. So, Pat Rowe was talking about, the possibility of just doing, ACA open enrollment right now, because we're right in the middle of it. So for those of you who may not be aware, open enrollment, started November 1st, it goes through December 15th. It's half as long this time. It's also not being advertised much, because the advertising budget was cut by 90%, so it's great to try and help people know about that. Now is the right time for them to get on there, and it sounds like it might make more sense to try and do it via the phone number versus all online. It is a complicated process. And I'm sure that there are some navigators around still that their budget was cut to, so that's Take Care Utah, and we'll put all of that in our resources of the month. But that's a really good thing to bring up and remind folks of, that right now we should be helping, get the word out about open enrollment for Obamacare or Affordable Care Act for those who benefit from it.
So just slightly dumb question, is how close are these parents to being 26? Not super
Not
close?
more.
Okay.
For 19.
Okay, well, we got a while then.
Yeah.
Okay.
211 still have navigators.
211, I'm sure if they don't have navigators themselves, we'll connect you with whomever. The problem is, though, that I think Take Care of Utah's budget was slashed by about 60%, as were all these kinds of programs. So it just might be more of a wait time. So another reason to do it sooner rather than later. We still have 1 month, which is great, so that you can take that time to work through all the kinks of getting enrolled.
Oh, Jade already provided another link
Yeah.
to sign up. Can
Okay, thank you, Jade. We'll grab that and put it in the notes.
Yeah, and the telephone number too to call.
Okay.
Thanks, Jade. And then we had Nikki joining us.
Oh, great. Welcome, Nikki. Okay, anybody else? All right. Well, thank you. That was helpful, good information. All right, so Dr. Fruin, if you would like to come up, I think we can turn it over to you.
Anybody?
Oh, thank you.
Hi, everyone, and it's nice to be back. I kind of missed coming to these meetings.
Nice to have you
I
back.
think this is an amazing organization. I feel, and I felt this in the beginning when I used to come to these. But the reason I'm here today is really to promote that practices increase screening for lead poisoning and increase testing for lead poisoning in the state of Utah. And the way it may pertain, I know these are care coordinators in general, but you're dealing with children with special health care needs. And although we do recommend screening all children, it is a recommendation. It's becoming a stronger recommendation through the CDC and the American Academy of Pediatrics. Certainly, kids that have elevated lead levels are at high risk for a lot of problems. So I'm just going to kind of talk about what lead is, why it's still a problem, what the problems in Utah are, and what we need to do, and how we're going about trying to improve the problem that we have. So just a little bit, why is lead toxic anyway? And so like some other elements, zinc, copper, manganese, it really has no biologic function in our body. It has the ability to replace other cations in our body, such as calcium, magnesium, and iron. It disturbs the biologic metabolism of the cell, and also it changes enzyme regulation, affects neurotransmitters, and cellular signaling. So everybody's probably heard of Flint, Michigan, but as far as lead goes, I mean, it really has increased awareness in the the world of pediatrics, and probably pregnant women. But just a brief update, or brief of what happened in Flint. So the water source was changed from the Great Lakes, Lake Huron, to the Flint River for about a year and a half, from in April of 2014 to October of 2015. And this water was much more corrosive than the lake water, and they did not add the anti-corrosive that they should have added to the river water, and so because there was old lead pipes, it caused lead to leach out into the public water supply. And although the residents have been complaining about the color, the taste, and the odor of the water for quite a long time, they did not issue a lead advisory until almost a year and a half later. There was a pediatrician who discovered that she was seeing, or that noted that there was increased blood lead levels. They had doubled and tripled in some areas of the city. And so she began this sort of investigation and found out it was tied to the change in water to the Flint River. And what she says was that the corrosive, untreated water created a perfect storm for lead to leach out into the plumbing, into the bodies of the children. And she has become a very important spokesperson in the lead community, has received a lot of awards and a lot of money to help with follow these kids. So this is very recent, but the outcomes of this Flint crisis, they looked at a bunch of comparable cities in Michigan during the time that the Flint water was used over that year and a half, and found that there was a decrease in fertility rates of about 12% during this time period, and a 58% increase in fetal mortality in kids in gestation above 20 weeks compared to other Michigan cities. So that's huge. I mean, that's huge. And they've raised a lot of money, millions of dollars, to actually follow these kids and put efforts into offering them services when they need it. Make sure the kid's getting his fingerprints. So why do we use lead? What's the history of lead? It's been used for thousands of years because it's got some really amazing properties. Anti-corrosive, fire-resistant, anti-knock. It insulates against X-rays and gamma rays. The Romans used it, calling it the king of metals, using it in water pipes, using cooking, dining ware, cosmetics. There was a phrase, crazy as a painter, because it was used in paint. It was used in birth control. It was used in coins, and as a sweetener, as a food condiment. Great slide, was awesome. Anyway, we've known that it has harmful effects for many, many years, but because it was so useful, it was continued as a basic tool throughout ages. Lead is mostly extracted from copper ore, but it also comes from zinc and silver. We have a copper mine here, everybody knows. So a psychiatrist in the 70s named Herbert Needleman that came out of, I believe it was Pittsburgh, sort of began this whole process of trying to get lead out of common things in our environment, because he discovered that even low levels of lead resulted in severe brain damage in infants and kids. He did this studying baby teeth. He also studied adolescents and followed bone X-rays. You could see lead lines and bones, and this is an X-ray of a femur and tibia and fibula. But he found that adolescents who had higher evidence of lead on their bones had a much higher risk of aggressive behavior and behavior disorders. So his studies were the catalyst for change for the CDC and the EPA to issue guidelines to reduce lead poisoning in children. This led to the phasing out of lead gasoline and lead paint. So lead paint in about 78, lead gasoline probably in 1988. Lead is still used in aviation fuel. So since 1991, the CDC has started recommending routine lead screening, and then sort of switched over to targeted screening in 2005 based on what was going on in a particular state or environment. But in 2005, the CDC and the American Academy of Pediatrics both adopted a blood lead level of greater than or equal to 10 micrograms per deciliter as a level of concern, indicating we needed to do closer medical and public health management. So again, 2005 came out with the number of 10, just remember that. But then in 2012, so 5-6 years ago, the CDC then made a statement there was no safe level of lead and adopted the use of greater than or equal to 5, so half as much. This was based on a study, a CDC study called the NHANES study, and that 5 was supposed to be used as a trigger to guide clinical and public intervention. Last summer, again, I think based on what was going on in Flint, Michigan, the American Academy of Pediatrics came out with a policy statement that was very strong on improving lead testing and screening in all kids. There's a reference for that at the end. So these are some cool, I think, real slides about lead paint. The Satio Yummy paint, Dutch boy. Okay, what can lead do to kids and pregnant women? So, like I mentioned, even levels less than 5 can result in lower IQ scores and academic performance. And interestingly enough, if you kind of look at total loss of IQ scores, it's these lower levels, it gives this cumulative greater loss of IQ scores because we have more kids that have low levels. But if you kind of look at kids between, like, up to 10, potentially a loss of 6 or over IQ points. If you look at kids, like, up to 30, maybe up to 9 IQ points. So it's just important to remember that even low lead levels cause a decrease in IQ points. This is through the AAP policy statement that there's an estimate of up to 20% of ADHD may be attributed to lead exposure. Whether that's true or not, I don't know. I think that's huge, though. Again, mentioning low birth weight, spontaneous abortion, reduced growth. Younger kids absorb lead much better. They are at higher risk because they crawl around, put stuff in their mouth, we all know. It also crosses over to the blood-brain barrier better. And it's important to know that any lead is cumulative and it's mostly silent, and it's stored in the body and the brain, in the teeth, in the digestive system. So a little graph here shows how it affects adults and children. As mentioned, reproductive, body, hearing loss, lower IQ disabilities, potential kidney damage. There's been studies on that in adolescents. More little poster-type things of showing what it does. And pregnancy, again, it's important, probably that we're going to be pushing towards testing pregnant women as well. So this is just kind of a list of all these places that I never knew where lead is still found today. So things like power cords, bulk remedies, aviation fuel, artificial turf, roofing, cooling, nuclear reactors, sinkers, organ pipes, picture of raw lead, where it's been melted. And these are just countries where lead is produced. The U.S. is in there. So it's still a problem in the USA, even though we've kind of forgotten about it a bit. It's still Flint, because 24 million homes have deteriorating lead-based paint, and 4 million of these still have young kids. I think there's about 500,000 U.S. kids, 1 to 5 years of age, that may have blood levels above, greater than or equal to 5. 2.6% of preschool-age kids have blood levels greater than or equal to 5. That's huge. I mean, if you think about it, when you compare it to other diseases like congenital heart disease and stuff, I mean, more. So lead can come through air, food, water, dust, soil, and through the blood. The most common source is through ingestion, so actually eating it, so lead-based paint, dust, those kind of things. But it can also be inhaled, where it's absorbed even better. So if you think about like rifle ranges, guns, stuff, inhaling lead dust. It usually goes unrecognized with no symptoms, and its effects, as I mentioned, are cumulative, and you can't really get rid of it. So the best way is to try and prevent exposure. And again, no safe blood levels have been identified in kids. And importantly, lead levels may be many times higher in refugee children. What I've read, up to 14 times higher in refugee children. Pakistan is the big one. Why is the problem in Utah, and why this whole initiative is going? Until very recently, the Utah State Lead Plan defined as elevated and required intervention only for levels greater than or equal to 10. So we were not following the CDC's and the AAP's suggestion of greater than or equal to 5. We've been a targeted testing state, which means it's not required to test lead in kids, but we should test it if there's concerns on a screening questionnaire between 6 months and 6 years of age, or if they're living in a zip code with greater than 27% of homes built before 1960, or if they're on Medicaid insurance, and that's a mandate. That's mentioned below. There's a mandate to test all kids with Medicaid at 12 and 24 months of age, regardless of question screening results, and we think that maybe about 20% or so are probably being properly tested and reported. Not very good. More problems in Utah. Since 2015, all blood levels have been required to be reported to the state of Utah Department of Health Environmental Epidemiology Program. A lot of people don't know that. Most commercial labs, so if they go to Intermountain or the U or whatever, they know that they're supposed to report it. But if you're doing, got the lead testing machine in your office, there's a big gap there in reporting, and there's some issues with the machine and how we're able to transmit information. So the big problem is we have so little data to know if we have a problem here in Utah. We have 52,000 births a year, but in 2015, there was only 1,392 blood lead levels reported in kids aged 1 to 5. If we look at reporting based on CPT codes, there were 7,000, but still that's just nothing. It's horrible. So we have no idea if we have a problem here or not. We used to, I think as providers, used to screen a lot more than we do right now, and I think it's because a lot of people weren't seeing the 10s, and so they just stopped doing it. I know when I was in practice, that's what happened to me. I just sort of stopped doing it, and I wasn't great about asking the questionnaire, giving a questionnaire, so I figure other people could do a better job as well. And when I started thinking about this project, I really think Head Start was the only program that was sort of routinely requiring kids to get testing done, but it's usually at age 3 or 4 when they're going into Head Start, which is kind of too late. And we have some just really basic data from Head Start, and it's concerning, let's put it that way. I put some of these levels down. It's not very comprehensive, but there are some reasons to be concerned with kids having elevated blood lead levels. So lead in drinking water, you probably heard about that some this summer. A kind of report came out, and the Safe Drinking Water Act limited the amount of lead that could be found in plumbing and solder after 1986. So if you got newer pipes, then it's less likely to have a problem with lead leaching out. It is not possible to totally eliminate lead from water, but the source is usually old corroded pipes made of galvanized steel. As mentioned, there was a recent study that found elevated lead levels in Utah public schools. They tested 188 schools. It was a voluntary thing. There's no, the Department of Water Quality, I believe it's called, they have no jurisdiction over testing schools, so this is a voluntary thing, but they found 10 levels, and mostly in the Granite School District, that had levels greater than 15 really parts per billion or micrograms per liter, which is the definition of EPA elevation. Most of these are older schools, and flushing will temporarily eliminate this high levels of lead in this water, but sometimes it's an easy fix, like a water fountain or a faucet. So this, I think, is interesting, this, as far as pediatrics goes, that some of the baby food, juice, apple and grape, they looked at actually had was more likely to have detectable levels of lead than regular adult, regular kid or adult juice. This is an advertisement from, I don't know if it's China or whatever, their anti-lead campaign, which is don't eat off the floor. This is just a reminder that a lot of people have guns here, we do a lot of shooting, and there's been studies that show people that even go to rifle ranges may have like 8 times the level of lead. So this is what we're doing in Utah. So back in November of 2016, I kind of put together this lead coalition for the state, and include state and private partners, and our goal was to improve lead screening, testing, education, and reporting in Utah. First goal when we got together was to change the lead reporting rule for the state so that it reflected what the CDC recommended since 2012, which was greater than or equal to 5, was the definition of action for elevation of lead. And we did this. We accomplished this as of August, although if you kind of look at the state lead plan, it's still not there. But we did, Dr. Miner from the Health Department did sign that. So it is effective that 5 is our new standard. And then our other goals, as mentioned, one of my major goals was to develop uniform screening questionnaires, follow-up guidelines for state and private programs, how to follow up even with low blood levels, and then to do education such as this and the public. Some ideas I had were to test pregnant women and children in WIC, kind of working on that. Maybe pushing testing in OBGYN offices. Yeah, and I think maybe just making sure kids that have developmental concerns and stuff maybe have been tested, make sure that they don't have elevated blood levels. And then this is a huge thing. It's, you know, once we've changed the definition, so we're going to be getting more kids with elevated levels. We're trying to increase the testing, which I'm sure we will. How are we going to get this data to the state? How can we get it to pediatricians? Which format can we get it to pediatricians so they can look up and see if these things have been done somewhere? So my idea was to try and get it linked somehow to UCCCCN and or CHARMS. We're working on this. Had multiple meetings with UCCCCN, talking to the state of New York, and there's some other states that do this, and then to UHIN as well. So hopefully it will be a way you can tell, either enter data or tell if your kid's led, your patient's led levels. So who should be tested? I think all kids should be tested at 12 and 24 months of age, or at least once, regardless of how they respond to the questionnaire. All children with Medicaid insurance are required at 12 and 24 months of age to be tested. Any kid who has a positive response on the lead survey, pregnant women should at least be screened. And then refugee children, the recommendation is they should all have a blood level between 6 and 16 years of age upon arrival within 1 to 3 months. And then in the younger kids, 6 months to 6 years should be rechecked 3 to 6 months after. Sometimes they're going into older homes as well. And then progress. So groups on this coalition, just in the last, May and the last month or two, there's now been 3 grants received through our coalition. So I received what's called an AAP Catch Grant in May, and my goal is to educate pediatricians and residents, improve screening and testing. Salt Lake County Housing Program got a CDC grant, and I'm working part of that as well. And then Utah Physicians for Healthy Environment is receiving an EPA Lead Prevention Community Outreach Grant. And Aaron Samudio is from Utah Physicians for a Healthy Environment, and we hope to kind of partner with pediatricians, pediatric groups in different geographic areas, and maybe get champions to help spread this message. We want everyone to help us be successful. So there we come up, and these aren't final, but these were just an idea of what we want to do. This is our current Utah lead screening questionnaire and our Utah lead plan and the Medicaid manual, and it's really not very good, as you can see. 2 of the questions are pretty much the same, and it just doesn't have enough questions. So we came up with, there's a list here of a better screening questionnaire. There's some stuff on here we are going to change, some of the wording, but in general asks a lot more questions, and our goal is to have all pediatricians, family practice offices, Utah County Housing, anybody that wants to give a lead questionnaire uses the exact same questionnaire, and that we have on the back the high-risk zip code, so they can look on the back and see, I live in a high-risk zip code, I should get checked. And then the other thing we came up with again, we're making some changes, but kind of a quick guide for practices on what to do with some of these lead levels, who to report to, who contacts are for if you want to buy a machine, who the contacts for the coalition are, and then some recommendations from guidelines. This came through the CDC, kind of did it through the recommendations from the CDC and AP and made it our own. But once we get it finalized, we can send out a better PDF, I think, for that. And then you can get reimbursed for capillary testing and a bunch of references. And this is the other thing I was hoping people might do pediatric practice is maybe we made these posters. Erin actually made these posters, and it just talks about trying to keep Utah unleaded and some basic sources, and ask your healthcare provider to test for lead because it may be silent. We're hoping maybe to bring awareness if people could hang them up or see practices hang them up. And we have a bunch, so if you want to make, we're going to be making more as well. But any questions?
So what about the machine? Tell us about how practices could potentially get one.
I got donated to me. It's called Lead Tier 2, and it's made by a company called Magellan Diagnostics. And on the bottom of this sheet here, it's got the contact. I've been dealing with this guy for the last year and a half, Joe Keene, so I need to be happy. He actually gave me a machine to use for this. So I'm very aware it's about yay big. Supposedly it takes about 3 minutes to run the test. So ideally, if you were doing like a hemoglobin test at a year of age, maybe you could throw the lead thing in at the same time. You poke the finger, you get a little capillary tube full of blood, you plunge it into, I call it the magic potion, whatever's in there, and swirl it around, and then pipette it out, and then you put it on a little test thingamajig, stick it in the machine, and it runs. Usually we'll read levels, I think 3.3. If it's lower, it'll read low. If it's above, I think it's 33, it'll read high. So it would be easy to incorporate into your practice. I think it costs about $8 or so to actually buy the kit that you'll need, the cartridge that goes in. And I think reimbursement might be 18 or 20. I'm not correct stuff, but it is reimbursable. So I do have that. I could show anyone was interested in practice is interested in seeing that. I could do it. And my goal was to be able to go. I thought, we'll go out and do free testing and stuff, but after doing it enough on myself and like my husband, I realized it's probably not a good thing. You know, you really need someone who's going to be doing it regularly, day in, day out, like a medical, like you would do, incorporate into a practice. But if anybody has any ideas of how they'd want to use this machine, or if they could use it almost as a test type thing, I would be pretty dang happy to have someone use that. So if I knew it was a busy pediatric practice that would be doing it, I would be more than happy to run that out.
We have that machine in our office. We test that 1 and 2.
Okay.
We took our 9-month hematocrit and just moved it to 12, so we're doing 1 poke. And reimbursement is really good. That means you get reimbursed for the test and the collection of the test. So we test at 1, 2, and 5.
Well, good for you. Which practice is that?
So Valley is pediatric. Awesome, right?
What do you think about the machine?
Like it.
Okay, good.
It's easy to use, it's easy to calibrate, it's done everything in the kit, so you can run your high and low, you get 15 tests per kit.
Yep.
And there is some training, you have to collect it right, like your kit can't have bubbles in it, it has to be from the start to the line, or you need to make sure that that's accurate, but we like it a lot, and not that we want to make money, but we've had a process in doing it because it's good reimbursement.
Yeah.
So it's not rolled into like a well child visit?
No. We'll do the 1-year checkup, and then we do hematocrit, the lead.
And it's, I mean, really, it shouldn't be just Medicaid kids. They did a study, it's probably been 17 years ago, where they found in Utah, Medicaid kids were in any higher risk for lead poisoning than someone without Medicaid. So, I mean, if you're going to do it, you should be doing it on. You really should be doing it on. How do you report?
We kept logs, or handwritten logs, we can pull them on our computer system too. We have not sent them to anybody yet because it's local health department. But we're keeping them because we're supposed to.
Yeah.
Somebody.
So at the bottom of that sheet, that's the somebody.
Okay.
And so that's what the issue is. That's one of the reasons because there are people probably doing it, but we just don't have the data. And the problem with the machine is it doesn't store, more than an hour or so?
I don't know.
Yeah, so you have to, that's an issue that we talked to Magellan with a lot, is like, how do we, and it may be this UHEN or something can get some kind of interface with the machine so that it can get directly reported somewhere. So that's just starting, but it needs to be easy for you to know, how to be able to send it in. So.
Ashley is asking, how can we obtain a new recommendation that represents the changes so that I can update the providers? So she would like to update her providers.
Yeah, so this is what where is she from?
Ashley, are you from Payson UBP? Payson UBP has been sending in our logs weekly to Mark Jones.
Yeah.
Yes,
Doing it right.
yeah, so Payson UBP.
Okay. Yeah, so, I think we just have some brief, things we want to change on our questionnaire. We just had a meeting, actually on Monday, and there were some little suggestions here, so we'll do that. And then, like I said, I can give these guidelines, these final guidelines in PDF to Mindy.
Yeah.
And then she could send them out, and then we'll send them out to the Utah AAP as well. And then just keep doing all this promotion, and if they want posters or anything like that, they can contact either me on the bottom of this or Utah Physicians for Healthy Environment, Denny Cowley, and we can probably mail stuff out to them.
Did you hear all that, Ashley?
Is Ashley asking about the newly signed, Dr. Minor signed Utah-led disease plan?
Yeah.
I asked
Mark Jones, I'm like, is that up yet? And I looked, and I knew the answer was no, because I looked myself. But when's that going to happen? I don't know. Stuff moves slow.
Is there any sort of official documentation of the legislative procedure where it was?
It really wasn't a legislative procedure.
Thanks, Ashley.
It was a lead reporting rule change under injury, something or other. I can't remember exactly. So we didn't have to do anything legislatively.
Okay.
We just started working with the right people, or me writing letters, going through the things. So, but for whatever reason, the state it's not visible yet, but just so you guys know, it's fine.
But that's been a reputation for a while, hasn't it?
It's not
Like the,
2012 CDC, but Utah's 10. We never changed.
Using the under 5. Like when we
Well,
started, that was the recommendation.
Well, you guys were doing the right thing then.
I saw it.
You got the smart people. I guess, I don't know what to say, because, some people would never, there's a lot of confusion, like people didn't know that even, you didn't need to report unless it was 10 or above. And as far as action goes, it's the county health departments. I think if you've got a kid that's got like a really high blood level, there is the county or the people that are going to come in and actually do this. But it all has to be, that's something I need to get finalized even on something like this. So we make sure, guys, if you have one of these things, you know exactly who's going to be in charge of what, the county or whatever. So we'll do a little improvement on that. But yeah, you were all Utah Valley pediatric offices are just yours.
Oh, Payson,
Payson?
Plaza, and Provo.
Okay.
The rest of them.
So maybe you guys could be and maybe Aaron, we could get Mindy next. That could be our champion for Utah County or something, if we need help or something with that.
Yeah.
It could be the Utah Valley Pediatric Group, and maybe, because, you're doing everything right, it sounds like. You could help us spread this out.
One time.
Well, you
Today to enjoy.
I guess the only thing is you're keeping a log, and maybe it's not, maybe you need to figure out a way to.
Oh,
Yeah.
wow.
Yeah, and that's hard, because then they're gonna have to go in and, we need to make it easy for them as well. So, we need to make it easy for you and for the state.
So just curiosity-wise, how often are you getting kids above that?
We did above 5.5 a lot, like more often than you would think. Like last night, we had 19, and we had to call in. We had the whole family come in and test them, and we sent them to the lab. get, 4 or 5 a week that are above 5%.
How many confirmatories come back then?
Not very many. We only have 2 confirmatories come back, but typically, it's depending on the recommendations, we don't retest for will depend on the level, but you have the graph. But so 3 to 6 months we'll retest in clinic or to see how old they're in 1 to 3 months. So usually they come back okay or mildly elevated. Never has it been to 0 though. Now, and Dr. Adams, who's our kind of physician champion at our clinic, his big thing is there should be no less, there shouldn't be that 2 or 3 or anything. And so for him, if it comes back at 2 or 3, we're still giving them out the information on how to review blood in your home. And
I'd be curious to see what you're using and stuff too.
Maybe a lot of high, not high, but above 5.5.
Okay. Because again, we're with this coalition, we want uniform state handouts for diet because a lot of the stuff we tell about diet probably isn't really true. If you're just increasing calcium and iron, it's not going to make someone's low lead level go down.
Right.
It's not. So having a healthy diet may prevent lead absorption. Giving all that stuff later is not going to make it go down. So that's why we're trying to, have standards, so whether it's Department of Health or practices, standard WIC information for everybody. And we're going to try and do it. We're trying to do it all together. So you guys have what you need. And then, yeah.
No, we started with a screening questionnaire, and then we were having so many that we were having to send to the lab because the screening was positive, that we expected 0. And now we have 1.5.
I haven't heard of that. I like that. That's cool.
Do you have any information on the sensitivity, specificity of the questionnaire?
It's not as good after age 3. I know that, but I mean, as far as mine goes, the one that it's really a combination of other states, and it's just just what are logical questions, what are some things that aren't being asked. So. Not really, but if you look, I don't know if you saw those 4 questions that our state has. So it's just a little more comprehensive.
And it might be very valuable to try to test it to see more questions, the less likely. Making sure that it's valuable, and I wonder that taking a practice that tests everybody, testing through the questionnaire also for a period of time, and see how it correlates. It might be a compelling information for those who are
So, quickly, it sounds like we're doing a really good job of identifying it or finding it, but what is the treatment? Diet can be slightly on diet, and then environmental. We can't have that.
Trying to prevent the environment. So if you knew a kid that had a 4 or 5, and if you could give them information about what to check in their environment, and they were able to, mitigate that a little bit, and then you come back in a few months and you recheck it, and you knew it wasn't going up, maybe it was going down a little, I would say that was positive. Another important thing, I think this is kind of interesting, is that with Baby Watch Early Intervention, I've requested that they put that on their sort of automatic, lead poisoning above 10 actually goes on one of their automatic qualifiers for services. So parents choose, if they know about it, and if they choose that they're concerned if the kid has developmental delay, the kids have above 10, then they automatically are eligible for receiving services. So that's almost done, I think. But
it's really a matter of looking for the sources.
Yeah.
And negative sources.
Yeah.
And showing them.
Are there any resources to help with that, anybody that can go into a family's home to see, they do lead testing or?
They do that now for kids that have elevated, so that it's 10 or above, that's what they're required to do. There won't be enough people to go in there for every kid above 5. I mean, that's not going to happen. They won't have those resources. But if we're testing it and we're seeing this and we have a plan and we know what to do and we can give the parents all the information of everywhere they go and just try and look for it, and then we're following them. Their kid may have developmental delays, it may not. It may be related to lead, it may not. I think this Dr. Mona Hanatisha is saying, right now with Flint, everything's being blamed on lead poisoning, whether it's not or not. So.
Claudia, I'll just add that Salt Lake County Housing Department has a grant to go into people's homes, and renovate them, get rid of any sort of sign of lead. There's something like 30,000 homes in Salt Lake County. I know there's a lot of Utah Valley here, and I'm not super familiar with Utah County and what they have to offer, but I know that Salt Lake County has enough funds for 240 children, and I think less than half of that actually, like as far as numbers wise, their families take advantage of it. So they have a lot of funds available to go into homes and completely, I mean, we've had numbers like $10,000 to like change out windows, repaint, and renovate, and at no cost to the family. This is through the Salt Lake, you can go to SLCO.
Let's say housing program, do you think?
It's the Let's Safe Housing Program in Salt Lake County, so slco.org, Let's Safe Housing.
It's on the back here. We need to get more information other than just that,
Yeah, so,
but yeah, they do that, and they don't do enough homes, and that's one of the things that their CDC grant is to increase, renovating homes and stuff.
mhm.
Great. Thank you very much. So be sure and grab a poster on your way out if you're interested in putting one of those up. And all of this information will go out in our summary of the meeting, our resources of the month email. So, websites, contact information, all of that stuff. All right, we'll toss the baton to Eric. And Eric, if you'd like, I can put you can see all of your slides over here. This is your preview.
Yeah, that would look great.
So, hopefully you can, right there.
That works. All right, well, I was asked to speak today about EPSDT, and Gina Polomoni, another reason we're sad she's not here today, she was originally going to do this, and she called me last week and said, hey, I'm going to be out of town, do you mind punting on this for me? So, total punt it will be. Let me ask all of you, who knows what EPSDT is, what it stands for? Okay, besides the obvious culprits here in the... I've heard about this for years, and I can never remember the order of these. I've called it PTSD, any combination of all of that. Let me give you the next slide, and we'll show you what we're talking about. Because this is really the bread and butter of taking care of kids with special health care needs around the state. It stands for early and periodic screening, diagnosis, and treatment. And this is federally mandated through Medicaid, a program that helps, or I should say pays for kids who receive Medicaid to receive the services that they need. The only way I can keep it straight is I have to think in the sequence. What happens? So early and periodic, screening first, diagnosis, and then necessary treatment. And I won't read through every single one of these lists here on the slide, but the important piece is incredibly important, as we all know, to get children diagnosed early so we can provide them the best treatment and therapy solutions to maximize their lives and to help their families. It's very important that we do screening early on to detect children who may be at risk. Once we screen those kids, to get them in for a diagnosis, and then move to provide them with the treatment necessary. Here in Utah, we call it CHEC. So how many of you guys are familiar with CHEC? Okay. I've been skirting around federal circles for long enough that the EPSDT and CHEC, I did not know they were synonymous. But here in Utah, we call it CHEC. And CHEC is, I can't remember the acronym for what that stands for. Child Health. I'm embarrassed. I need to find my note here. Well, I'll tell you what, I'll tell you what CHEC stands for at a later time. Child Health Evaluation and Care. There we go. So that is what CHEC stands for. We do that for all of our Medicaid kids. So how many of you had to fill out a CHEC form when you have a Medicaid child that comes in for a, what does that CHEC form entail usually for you guys? What sorts of things are you?
All your vitals, anything found at that visit that day, what your treatment's going to be, recommended
And is that following along with those well-child visits for the kids? Okay. All right, very good. So, as I said before, it's Medicaid's comprehensive and preventive health program for kids under 21. So, generically, through kids through 18, some 19 and 20-year-olds qualify for it if they're on traditional Medicaid, if they're on a different plan. They don't qualify. It's definitely kids up through 18. Screening services at those medically appropriate intervals, so that follows along with those well-child visits. A medically necessary healthcare service, if the service is not available under the state Medicaid plan. So you have a little bit of wrangling there if you discover something that the child needs help with, and it's not a covered service. And the other important thing is they need to inform all Medicaid eligible persons under 21 that these services are available. And again, incredibly important for our kids who have special health care needs. Hey.
So, does cover it, does Medicaid have to cover it, or does the state cover it?
So this is Medicaid. The states are required to do it. Each state has a little bit of latitude with how they do it and what they do.
So, but if you discover something medically necessary,
Sure.
then you have to submit for payment to Medicaid. Is that how it works?
And a lot of times there are things, they do have a medical review type of a group as well. So sometimes those things, Harper Randall, who was our medical director at Children's Special Health Care Needs for years, she was part of a CHEC review committee. And so some of those medically necessary services would go before a review board, and they would typically give it, the thumbs up or the thumbs down. I want to say the majority of the time, with really good supporting documentation, they usually gave that a thumbs up for services that weren't always good. Marilyn?
For example, I participated in a couple of those medical check committees, and also have consulted a little bit, just briefly. But, for example, for speech and language services, some of them may not be documented that it's available to the child, and it has to be medically necessary. So they go to the committee to discuss it and determine if this child should have speech therapy and look at all the factors. And for the submitter, like for the speech therapist, to submit enough details that the committee would say, yes, therapy should be provided for this child. So they make a decision together and ask the professional on the team what their opinion is. Rather than just having the nurse care manager make the decision, we'll consult with a speech therapist or an audiologist or somebody else to determine the medical necessity to provide for the child.
Thank you. Okay, good question, Kate. Thank you. So this is just a brief rundown of what those services include. As you can see, that screening for vision, dental, hearing, lead poisoning. Wow, that was just right on cue, and I didn't even plan that. So these were slides that I pillaged from Gina. So way to go, Gina. Immunizations, lab tests, and then the accompanying health education for the family. So it's a relatively comprehensive and robust list. To be honest with you, I'm always glad when kids have Medicaid, because it seems like, it could be crazy to say, but when they've got Medicaid, sometimes fewer hoops to jump through to get services provided than sometimes with our commercial insurances. So almost a little less wrangling once a child is eligible for those services.
And Eric?
Yes.
Quick. So if you've got a Medicaid child and you don't have a lead care 2 machine and they're coming in for a well-child check visit, would you do the capillary draw and then send that off to the lab? Is that how that would work? Just in an order to the lab. I see. Okay. Okay.
Some people do it on filter paper. Some people just send a capillary, like make the huge, send the capillary tube off to the lab. It's done different ways, or in order.
So there's multiple ways that can happen.
If there's not an in-house lab that when they go to the lab, this would be a requisition. So just basically getting the diagnosis,
and referral and follow-up, so it's a relatively comprehensive process there. And then it says healthcare must be made available to treat, correct, or ameliorate physical, developmental, or mental health conditions discovered during screening. So again, if you're under 18 and you have Medicaid, you have a relatively robust group of services available to you. And I chose that word specifically, Claudia, robust, because you love it so much. She was my QB neighbor for a long time, and we had conversations about that, so I had to throw that in there. Okay, so interestingly, there are 170,000 kids in the state of Utah who receive Medicaid.
So are you talking, I'm still really new to this whole thing. Are you talking traditional Medicaid? Because the population of children that I work with, they'll have the commercial insurance, but they also have waivers and other folks of Medicaid. And so when you talk about Medicaid, are you talking about traditional coverage from this?
So when you so yes, traditional coverage, but you're also looking at these are generally parsed out into the ACOs. So the ACOs cover all of these pieces as well. So that's just contractually part when an ACO agrees contractually to be, a Medicaid ACO, they say we will provide these services. It's always been a partnership. So when we used to do direct service clinics through Utah Department of Health, and we entered insurance information, we would enter ACO information, and we'd also enter traditional Medicaid information, because sometimes if it was not contracted through the ACO to take care of a particular piece, the traditional Medicaid piece picked it up. So they kind of go in tandem like that. Traditionally, too, what you're finding with the waivers generally include all of this. The benefit of a waiver is you quite often have additional pieces that the regular Medicaid population does not. So, for example, the medically complex children's waiver, you end up with some of that kind of respite care piece that you wouldn't have just with general ACO/traditional Medicaid. Did that answer it?
Kind of, sort of. But for this group, too, I would also encourage them to submit requests for these kind of testing to your commercial. Totally agree with you. Sometimes jumping through the commercial hoops, it's fatiguing and it's terrible. But they will cover many of the things that were on your list, which helps the Medicaid budget make it go a little bit further as well. But
yeah, and I have a 21-year-old with type 1 diabetes, and so we've jumped through that commercial hoops lots of times, and usually after much cajoling, they acquiesce. So it is a lot of work, but definitely worth fighting for your kid. So 170,000 kids on Medicaid. Just off the cuff, what do you think the cost is per year per child to have a kid on Medicaid? Maybe that's something you've never thought of. I hadn't thought about it until I threw these slides together. What do you think? How much are we looking at it costs? $40,000 per child per year. Okay. Well, what was that? Okay. Let me tell you, about $35.66 on average per kid. Interestingly, though, if you look at the fine print at the bottom, the average cost for adult Medicaid enrollee is close to $6,000. So almost double that cost. That's why these services are so important. We say it's really urgent to get kids in early and treated, so hopefully we're taking care of some things in childhood we don't have to deal with in adulthood. Hopefully being the operative word there. All right, how many kids in the state are uninsured? We have 170,000 kids on Medicaid. I don't have a count for kids who have commercial insurance, but how many kids in the state would you say do not have any type of coverage at the moment?
I know of one. So at least
you guys are funny. Yeah, that was good. That was good. Okay. 65,000 kids are uninsured. National data shows, though, that of uninsured kids around the nation, 89.8% of uninsured kids could be eligible for Medicaid or CHIP. Again, that's why that CHIP push is so important. Almost 90% of kids that are uninsured could be eligible for one of those two programs. So it's getting families to know about it, getting them to apply, holding their hands to jump through the hoops, it's not easy. And if you have, as a parent, intellectual disability, if you are working 6 jobs trying to make ends meet, if you're just a busy parent, it is really tricky sometimes to do this. So I think a lot of folks give up. And, you know, when you're jumping through all those hoops and it's 4 months later, you still don't have anything, you finally just say, I'm done with this. You know, life's busy, I got a kid to raise, I can't be doing this. So that's why it's important to have that support and encourage folks to do it. It's really worth it to get that going and jump through those hoops to make that happen.
Are there support in like the emergency rooms or, I mean, it seems like being in a pediatrician's office, the kids we see have health insurance that covers the pediatrician's office. So, like, where are these kids going for medical care and how do they get identified? And
A lot of folks are emergency room users. And quite typically, though, there's really been a push, ever since I've been in public health for the last 20 years, there's really been a push at hospitals when you have a kid that is uninsured or underinsured to really push them into social work or someone that can really help them try to navigate that process. I know particularly kids coming out of the NICU, when you were looking at these astronomical costs for having a child in the NICU, they were working really hard to have helpers in the hospital and social work get with families to get folks applied for those Medicaid services. So there's a lot of help, but there can always be more. Our integrated services team, we're always happy to help families work through the process. And we can do as much or as little hand-holding as needs to be to kind of help folks do that. My staff sat down with families and physically helped families fill out forms. So if you have folks who just can't quite muster this big old jumbo application, our team can help. All right. That last number there, that would be out of the 65,000, about 58,000 more kids in Utah could be on Medicaid. I wanted to throw that out. Okay, this is why it is really important for us to not cut Medicaid budgets in the state. We lose $2.32 of federal matching funds for every $1 in state money that we cut from the Medicaid budget. So that's a sickening thought. That gave me the oogies last night when I kind of realized that. So just a really, really creepy thing to think about. Anyway, encourage families to apply for Medicaid. And if they're having trouble or difficulty navigating through the system, have them call us at Integrated Services. We could be happy to jump in and help see what we can do, even kind of piggyback on those cases, get in and see if we can help them figure out how to make it happen. The services are comprehensive, they're great, and they're really valuable for our children with special health care needs and just children in the state who qualify for these periodic screening and developmental tests. Just my last slide here is there's some helpful links. There is, the top one is Medicaid on a federal level explains the EPSDT benefits. The middle one is the Medicaid link, and it's about 20 pages on CHEC. This talks about all of the stuff that is available to kids. It's nice to look at this. It's pretty easy to read, not too comprehensive. And then the last one is just a Medicaid fact sheet for Medicaid numbers and costs. So, any additional questions? Thanks for putting up with me. Next time we'll let Gina do it, and she will probably be more comprehensive than I was. Thanks, guys.
Thanks, Eric.
Thanks, Eric.
Okay, so you have a couple handouts then?
I did not bring
Okay.
anything on paper because the link
Thanks,
is right
Chief.
there.
Okay, so we'll just make sure that
Yes.
it's sent out, pulled out and sent out in the.
Yes, it's okay.
Okay, very good. All right. Thank you. So, lots of great questions and discussion, which means that we're pretty much out of time, but we had hoped to maybe throw some ideas out there, if nothing else. So we've kind of talked about this last one a little bit in Eric's presentation, that perhaps you didn't know specifically about EPSDT, but maybe you knew a little bit about CHEC, and we're incorporating those for your Medicaid patients if you take them. But hopefully this has made you a little bit more aware of some of the things that are available to that population. And then, of course, we're talking about screening in general, and making sure that kids that you might be working with, because they are more complex, also be considered in your practices, screening, just generally. And so we are curious, maybe I'll just take a moment and ask, do you guys have influence in your practices to be able to advocate for a population or make changes in terms of the screening practices that get adopted? You know, it sounds like in Utah Valley Pediatrics, there's disparity in how things are approached. So some practices a little farther along, a little more robust in their approach to lead screening in particular. So would there be a possibility of a care coordinator in Utah Valley perhaps trying to push something, or what do you guys think? What's your ability to affect things within your practice? We did reach out to a couple of care coordinators before the meeting and saw that there are differences. It's definitely a range. So just something to think about as you're thinking about quality improvement projects. If you have the ability in staff meeting to talk about things, hopefully you're able to take some of this back, what you've learned, and share that within your practice. To start thinking, sounds like we've had a generous offer from Dr. Pruin to potentially lend that lead care 2 machine out if it would get utilized. So, and obviously there are other resources around the lead as well that could be pulled in.
On the lead machine, I'm pretty sure that we got our machine for free. You just have to agree to buy X amount of type kit.
I see that.
Yep,
Oh, that's good to know.
there's good deals, like, I think, yeah, you do like 500 or something a year that you can request to get it, I think, which is awesome. I would just ask, make sure you ask.
Yeah.
For sure, we got ours for free.
That's fantastic. Okay.
I would assume that you all would feel much more comfortable with all bringing information rather than trying to influence. So Mindy was asking, do you have what's your level of influence in the practice? I assume that you would feel even more comfortable to say, well, I'm bringing information I've learned, hey, I want you to do that.
Yeah.
Yeah.
Depends on which doctor.
It's true.
My office is my doctor's person, I've been there for a really long time. So if I'm trying to say, book of research, they're really pretty open to what do we need to do. We have other offices that as soon as we say that, it's like, what?
And it's true, and that's the response we got. So we got, like, your office or Wasatch Pete's chair nurses, they have a lot of influence in what is done, and then other offices is that we have no influence, but the doctors tell us, and then we do. Mm-hmm.
So this sounds like a question that we could bring up at our learning session in the spring to talk about how care coordinators can be a part of their coordination in that office with families and supervisors.
Okay.
All right, so it looks like Kay's got validations for you. Our next meeting is December 20th, right before the holiday season. We hope that some of you will be able to join us. All right, thanks, guys.
Thank you.
Have a good day.